Hospital SIR EMS Stroke Training. I'm Brad Robinson. I'm the EMS Coordinator at Memorial. And I also have with me Crystal Honnold, who is the clinical nurse specialist for Southern Illinois Healthcare. And she and I will be co-presenting. Crystal's going to cover the first approximately hour of the program, which is stroke anatomy and physiology. And we'll take a short break, and then the second hour I'm going to cover EMS based, which will be an overview of the protocol and then some EMS based scenarios on patient assessment, treatment and transport of your stroke patient. So also for those that are here, the restrooms are right outside in the lobby, and if you need anything, let us know. For those on the webinar, raise your hand if you have a question or concern. And at this point, I will turn it over to Crystal.
Anywhere specific, Mike, I should point this to get it to move? Yep. It's not. So maybe Mike might click this for me. So here we go. We're just going to roll with the punches. That's the goal today. So ischemic or hemorrhagic, that's always the question you have when you pick up a patient with the signs and symptoms of stroke. So ischemic means it's some kind of infarct. It's not feeding. Think of it like plumbing. We block the plumbing. That's all that the vascular is. We block plumbing. You've got thrombus, emboli, or hypoperfusion for some reason, low blood pressure. You don't have high enough water source, things like that. Or hemorrhagic is where the pipe bursts and now you've got a mess in there. You've got the blood everywhere. So if we go to the next slide, this is your prevalence. It's the 4th leading cause of death in the U.S. We got bumped from the 3rd leading cause a few years ago to cancer. Cancers and things like that bumped us out of it. However, we may not kill you, but we will disable you, is what stroke does. We're the 1st leading cause of disability. So our incidence is about 795,000 new strokes per year. 610,000 of those are first-time strokes, while about 185,000 are recurrent. So that's where that secondary prevention really comes into play. Every 40 seconds, someone in the U.S. has a stroke, and 53.9 billion is an annual economic burden. So that's the disability part that really hits the economy and Medicare, Medicaid. Okay? So we're going to go to the next slide. I'm sure that everybody has seen this, am I correct? And it changes and now it's updated to a pretty blonde that has a stroke. But this is just a nice cartoon with your FAST scale on it, the face, arm, speech, and time. One positive sign indicates a 72% chance of stroke, and that's when you would notify and roll forward with the signs and symptoms of stroke and call the local hospital. Go ahead. So TIAs, a lot of symptoms happen in our TIAs, and what happens is this is something that resembles a stroke, and it typically clears in about the first hour or shorter. But it could also clear in the first 24 hours, but we're not going to wait 24 hours to see if it clears. Most reverse between 60 and 90 minutes. There's about 500,000 cases of these per year. These are the warning signs for a stroke. So if you've had the TIA, you still need to come in and be seen and get help. If you don't, that's where the problem lies, because at 48 hours, 5% will have a stroke. At 3 months, 10 to 15% will have a stroke. At 6 months, about 60% will have a stroke, and by a year, at least about 80% will have a stroke. So these are the really big warning signs, and this is why we treat TIAs just as seriously as we do strokes. Okay? So, hopefully my slide comes up. Signs and symptoms of a true stroke. Yep. So, little technical difficulty. Yeah, go ahead, put them all up. It's one-sided weakness, numbness of the face, arm, or leg. We have a visual disturbance or loss of vision. Loss of speech, trouble talking or understanding speech. Sometimes they may just have trouble finding words. Not that we don't all every day have that issue, but it's every other word. It's really difficult speaking. They're not able to follow your commands when you ask them to lift an arm. They're not going to be able to, but if you show them, sometimes they'll be able to. The sudden severe headache without apparent cause makes me always think hemorrhagic. Ischemic don't typically cause problems with the headache. Sometimes they do, but that smashing sudden headache is typically hemorrhagic. Ooh, my clicker works. Unexplained dizziness, unsteadiness, or sudden falls, especially with any of the previous symptoms. The people that we really, really miss are the unexplained dizziness. We think they're drunk or they're hypoglycemic, and we totally miss those cerebellar strokes, which are more deadly than the others because it's right by the brainstem. So when that starts swelling, we really have some issues. Classifications of strokes, 87% are ischemic, whereas only 13% are hemorrhagic. The hemorrhagic are some kind of intracranial hemorrhage or subarachnoid hemorrhage. And that's typically, intracranial hemorrhage is almost always related to some kind of hypertension. Then ischemic, you've got other, which means we have no clue why, really. Cryptogenic, cardiogenic, you've got your lacunar thrombosis and your large thrombosis. So, A&P of the vasculature. This is a website that you can go to that really shows some good images, but we're really going to talk a little bit more about the plumbing. And I'm not going to make you look at this video. It's not a video. It's just a long slide, but it's really good for you guys later on that you can look at if you want to. But I thought it would be interesting. This is a brain, and this is all the vessels in the brain. So think about all the little plaques that flip off, all the little things that occur, and why you might have some problems. Even those little lacunar infarcts and little TIAs and things that happen. There's a lot of little crevices and places that that stuff can go. Okay? So physiology of the thrombosis. You can see it down here, and there's also a website that you can go to. This is when obstruction of blood flow due to a localized occlusive process within one or more blood vessels occurs. So the thrombosis can occur for multiple reasons. One, you've got a high cholesterol. And the high cholesterol, the fatty pieces are floating around in your blood, and they start accumulating and cause a buildup either on the plaque or just along the vessel walls, narrowing them, causing the problem. So think about it, like I said, like your plumbing. How many of you have spouses that you clean out the hair? Because what happens is in your pipes, all that hair slowly starts going down, and then what happens is a big chunk of it finally breaks off and occludes the plumbing, correct? Because my husband complains about this, so I'm sure that some of you deal with it. Or what happens is you have that narrowing where the water just slows and doesn't want to flow down, and then you still have to clean it out because now you're not getting enough flow to the brain, and it can cause problems. So those are some of the ways that the thrombosis can happen. Like I said, you can go to that site, and it's got a nice YouTube video to also show how that plaque formation occurs and things like that. Okay? What am I going to try? Oh. So a clot forms, an embolus is a clot formed somewhere else in the body, then lodges in a cerebral artery. So big groupings of people that this happens with is your AFibers. Why? Because we don't like to take medicine. They don't take their Coumadin or their Pradaxa, whatever they're on, or they get taken off of it because they're getting ready to have their teeth surgery done or something that happens. And then a little clot forms in the heart, and when it starts beating that abnormally, if I could talk today, then it flips off and goes into one of the major vessels, such as your carotids, and then occludes and causes us some problems. Okay? Those are the two biggies that happen right there. The other thing that can happen is hypoperfusion, and it occurs with any significant reduction in blood pressure, be it just a drop because they took too much antihypertension pills, because we've all had those patients where they had high blood pressure because they felt their headache coming on, so instead of just taking one of their pills, they'll take 3 or 4 because they forgot it for the last 4 days, so they'll make it up in one time. You know what I'm talking about. Or sometimes as syncopal episodes, they present in their TIAs, or they've had a small stroke. But this can cause like a global ischemia, not necessarily just a one place. This is that global ischemia. And they call it the watershed infarct. So it's kind of a global, it's over multiple areas. So that's where it happens between two terminals of two adjacent cerebral arteries. See, it's the afternoon and it's nap time. I can't talk. So that's what happens is then you've got this nice watershed infarct, and a good portion of the time these patients are going to end up with a carotid endarterectomy or a carotid stent to open up those carotid vessels. We actually have recently had a couple of patients that they came in with syncope and we found a nice huge watershed infarct on them. So now, everybody knows about the infarct area, but when you say the word penumbra, a lot of people are like, what in God's name are you talking about? The penumbra area is actually the area we're trying to save. We're not going to save the infarct area at all. It's already dead. There's nothing we can do about it. What we want to do is save that penumbra, that infarct area that's outside of it. When you think about the penumbra area is that surrounding area that is fed by that vessel that's clogged, but it also has collateral flow from other places. But right now it's not getting what it needs. So it's like, yet again, your pipes. You try to take a shower, but somebody has busted a water main somewhere, so now you've got low pressure, and it just stinks, right? That's what we've got here. We've got a low pressure. We're not feeding the brain where we need to. So what we're really trying to save is that penumbra. We want to open up that artery or vessel so that we can feed that area and not lose any more and cause an even bigger, deader space. I hope that makes sense. So why do we have to hurry? Why do we talk about our door-to-needle times and hurrying in, and why we want pre-notification from EMS as much as we possibly can? And why do we tell people to call 911, right? Besides the fact that you guys are better at probably treating strokes and stuff than the patients are at home. Every hour a stroke goes untreated, the brain ages 3.6 years. Every minute a stroke goes untreated, up to 2 million cells die, 1.9 million neurons are lost, 14 billion synapses are lost, and 7.5 miles of myelinated fibers die. That seems like a lot to me. So that's why the door-to-needle times and things like that are so important. So we're going to talk about our stroke syndrome 1. Jeepers. ACA, our anterior cerebral artery. It's a small vessel, provides blood supply to the frontal lobes. This isn't occluded very often. Okay, it's not a big, huge area for ischemic stroke. I will say it is the ACOM artery is a bigger area that we have a lot of aneurysms on and aneurysmal ruptures. And that's because if you notice right there at the top, it has a lot of bifurcations or twists and turns that when you have hypertension, little bubbles like to pop off and cause your aneurysms. All right, Mike. That's because Mike is messing with me on the computer. ACA, cognitive impairment. Personality changes can happen. They end up with a flat affect. Slowness of reaction. They're tearful. We call this pseudo-bulbar effect. They'll be very depressed almost looking, and yet they're not depressed. It's just because their affect has been affected from where the stroke is at. And they'll cry sometimes for no reason. They'll just be standing there crying at the most weirdest times. So you've got contralateral lower extremity, sensory and motor deficits, foot drop, impaired gait. Your motor strip is right behind your frontal lobe, so that's part of where it feeds. Your stroke syndrome 2 is your posterior cerebral artery. This is a small vessel. It provides blood supply to temporal and occipital lobes of both hemispheres. So when we talk about occipital, always you're going to think vision. As I see here, vision change, that's going to be one of your most common. You're going to have some ipsilateral visual deficits, maybe some nystagmus, some little loss of depth perception. Shouldn't have the slurred speech that I have right now. Visual hallucinations, possibly cortical blindness, and it's from the brain injury. It's not from any vessels in the eyes. And then, let's see if I can say this afternoon, homonymous heminiopsia. Not bad for this afternoon. Memory deficits and perseveration. See, I can't say that though. So, it's coming up on a slide, and the visual, I always do great with the visual, and I think that'll help. We'll get through these, and I'll show you the slide. So the middle cerebral artery You see this large artery here. It's a large vessel. So if we occlude the middle cerebral artery, you're looking at the big strokes. These people are going to have a one-sided weakness. This supplies frontal, temporal, and parietal lobes. These are the motor and sensory ones that you see. They can't talk well. They've got the weakness. They've got the huge facial droop. These are huge strokes, okay? And this is the most often occluded. Go figure. I think Mike's messing with me again. So MCA, you've got the ipsilateral. I talked about the sensory and motor deficits of the entire body. This is that lower face, the cheekbone down. They're going to have that huge facial droop, arms and legs, aphasia. They're going to have the visual problems. And they may or may not have that decrease in level of consciousness. Just depends on where we're at with the stroke. So when we talk about hemianopsia, you've got partial hemianopsia, which is that first slide where the quarter is cut out. For us in the hospital, that's an NIH of 1. So there's blindness in quadrants. When you look at the peripheral fields, they've got one quadrant that's just gone that they can't see when you try to test their vision. And I hit something there. Sorry. You've got complete hemianopsia. So that's half the visual field is gone. So one half of the side there that you see is gone. And they're not going to be able to see to that side. A lot of these people with the complete hemianopsia will be gazing to one side, and they're not going to want to look at you on the other side. They're not even going to know you're there, which sometimes you'll scare them because you'll come at them from the side that they can't see, and they don't, until they hear you, they don't see you. And then you've got bilateral, which is blindness in quadrants or hemispheres in opposite directions. So that's literally, there goes your peripheral vision. Opposite directions and looking out, which causes problems. So visually, remember this. It's kind of interesting to see, especially on patients, as you scare them sometimes. So, stroke syndrome 4, internal carotid artery. This is contralateral hemisphere, hemiparesis, face, arm, and leg, hemianopsia, dizziness, aphasia. You've got headache over the opposite eye that's affected. So if it's your left side affected, it's going to be your other eye that's giving the headache. These patients, they end up typically getting a carotid stent or carotid endarterectomy like we talked about, 70% occlusion. They're at higher risk for an MI also, because if they've got enough plaque and fatty built up in that huge carotid artery, more than likely it's other places, and that puts them at a higher risk, which is why we always request that EKG in the stroke, because we don't know where the stroke is at, and that'll help us rule out to make sure that they don't have an MI at the same time, since they're equal risk, especially on these strokes. So stroke syndrome number 5 is the vertebral artery. This is the hard one, because this is the dizziness, the nystagmus. They may have some dysphagia and dysarthria, so trouble talking, trouble swallowing. They may or may not have some numbness and weakness on one side of the face. They have that staggering gait, clumsiness, some ataxia issues. These are the hard ones to diagnose, because you think, well, were they drinking? Are they just blood sugar low? Are they psych? You don't know. And you're trying to figure it out. And so these get missed quite often because it's put off to something else. It is even put off to they just have some vertigo. And then 2 days later, it's not any better, no matter how much meclizine and things you give them. You do a head CT and you find a nice little cerebellar stroke. Okay? So then you have basilar artery stroke. These are the really bad strokes. They don't happen very often. Has anybody heard of locked-in syndrome or seen it? Just kill me. This is literally a locked-in syndrome. Happens from this, and you can't. All you can do is move your eyes. That's the only part of your body that you can move when these occur. It's devastating. It's mortality of 75 to 85%, and then people probably are fine with that. You're focusing on their abilities, not their disabilities, and pretty much their only ability is to be able to move their eyes back and forth and blink. There's some really interesting books called The Diving Bell and the Butterfly. And it's actually about a Vogue fashion designer and editor that had actually helped start Vogue, had a basilar artery stroke, and wrote a book with just his eyes. And it's a short read. He wrote it with his eyes. So, but it's really good, and they also have a movie around it. Everybody's laughing at me, but yeah. And so, but they also have a movie around it. And it's really nice and interesting to see because you kind of get the patient's perspective, and if you ever see one of these patients or take care of them, you'll understand, especially after seeing that movie. So right versus left-sided strokes. So left side in the brain, right hemiplegia, you've got some expressive aphasia, maybe some receptive, global aphasia, intellectual impairment, slowing cautious behavior, and defects in right visual fields. Does everybody get the expressive and receptive aphasia? So the expressive aphasia, there you can't talk. Receptive, you don't understand. The benefit, the expressive aphasia is hard because they'll be able to follow commands when you tell them, but they're going to try to tell you stuff and they're not going to be able to. It's going to make no sense if they're even able to speak. The receptive aphasia, they don't understand you. They look at you like you're crazy. But when you show them things to do, they can do it. If you say lift your arms, they're not going to do it. But if you actually do it, they'll do it. Global aphasia, unfortunately, means it's both. It's a mixture of both of them that's wrapped all up. So they don't understand you and they can't talk to you. So that's sometimes where you get these neuro patients that get a little combative because they're just mad. I'll get out at you. So right side in the brain, your left hemiplegia, spatial perceptual deficits, denial and deficits of the affected side, tendency for distractibility. They're a little bit more impulsive, unaware of the deficits. These are the patients that are going to get out of bed and fall. You're going to pick them up at the nursing home because they got out of bed and fell. Poor judgment, defects in the left visual fields. So those are the kind of the differences between the sides and what's where. So if it's right-sided, in the left side of the brain with your right hemiplegia, I get confused sometimes, you're really going to have some more of those aphasia issues versus if it's in the right side of the brain, you're not going to have as many, if that makes sense. So hemorrhagic stroke, this occurs when an artery escapes from its normal confines. This is what it means when in regards to plumbing. Think about in the winter when your pipes freeze and then they start thawing and they burst. It burst. This can be related to an aneurysm. This could be related to high blood pressure. Smoking sometimes is the only history on these patients. They've had no high blood pressure. They don't have an aneurysm, but they have a history of smoking, and you'll find it due to the fact that smoking just weakens vessel walls, and as we understand more and more about the vasculature, we realize how bad smoking is. Blood irritates that tissue around there, causes edema and increased pressure. A lot of the times, these are going to be the patients with the severe headaches. They may not have a sided weakness because they're probably going to have a change in level of consciousness. It's about 10% of your strokes. If you ever transport patients going back to a nursing home and they talk about a hematoma, an intracranial hematoma, it's a hemorrhage. I always love when they flip words. So subarachnoid hemorrhage is one of those hemorrhages. It's blood ruptured from a weak vessel into the meningeal space. AVMs are also a possibility that this is the reason that they ruptured, the arteriovenous malformations, which is just a big, huge birth defect that you're born with of a whole bunch of arteries and vessels that are just congealed together. They have the explosive headache that we talked about. Mortality rates for subarachnoid hemorrhages are about 40% in the first week. So nice subarachnoid hemorrhages are not good. In about 6 months, about 50% mortality rate. So this is just an intriguing photo for me, especially as they're getting more and more into the brain. This is a stroke survivor brain. Obviously, he did not survive at this point because this is his brain, right? Who had donated his body to science. There's the area of infarct, so I want you to see that should be nice and plumped up right there, and it's not. And that's because that's what died, and then they had to figure out, his brain had to figure out how to work around that, if it did. I don't know if he got treated or not. It's just a nice photo to see how much damage is done by having a stroke and what the brain actually looks like. There's one other thing. There's one other thing that can happen, and that's the carotid artery dissection. So these happen sometimes, and this, I love chiropractors for certain pieces of it, but if you get some chiropractors that manipulate the neck, you've really got to watch. And we always ask, have you been at a chiropractor recently whenever they have a stroke? Because sometimes when they manipulate, they can actually cause a dissection. And that is literally where one of the inner pieces of the vessel wall breaks and falls over. So think about your vessel walls. There's multiple layers, just like there is in a house. And so it's like this drywall falling in, and it dissects in. And that can happen just as a little dissection and can block the blood flow. So I'm great with their trigger points, and they can manipulate my back and massage, but I don't want them to manipulate my neck. Okay? This is just a little different view where you can see how it occludes and the damage occurs. So about 50% of these people that end up with a carotid artery dissection will end up with a pretty decent sized stroke. There's some genetic predispositions that can also happen with it, which is Marfan syndrome. And I'm not even going to try to pronounce that second one. It's like pseudoxanthoma elasticum. And then Ehlers-Danlos syndrome type. All right. So it also can be caused by blunt trauma, manipulation of the neck, you know, when they crack your neck. Lifestyle risk factors. It's the most common cause besides the PFO in young strokes. Okay. I'm going to show you some slides. This is Marfan syndrome. So you kind of see what these patients look like a little bit. Then there's your pseudoxanthoma elasticum. And then your Ehlers-Danlos type patients, which are interesting. I don't think I could pull my skin off like that, and that's a good thing. So symptoms can include headache for carotid artery dissection, neck and face pain, especially around the eyes. So around their eyes just hurt. It's almost like they have a sinus headache, but it's really not. They may have one droopy eyelid, but that's all that's droopy. Or they may have some double vision. They may have a decreased sense of taste. And there might be a little bit of weakness on one side of the body, but there may not be. So treatment for this is to anticoagulate, because obviously you don't want plaque or a little blood clot to hit where that wall collapsed. Or they could end up going in and doing an angioplasty or stents. And that's just a nice photo of it to show. So I am finished, but you guys are just getting started. So if I put you to sleep, I'm really sorry. Brad is going to start, and so yay, because he's more EMS than me. And so I think coffee, we'll take a little 5-minute break for everybody to make sure everything is working on the webinar end, and to make sure you guys get a drink or coffee if you need it that are here. Okay? And just an FYI for those, you've always got Leslie or Hope as our educator. Leslie's one of the stroke coordinators. I don't have Amy's name up here. For some reason, I don't know why, but Amy Treese is at Heron now for Williamson County area. So if you have any questions, just let us know. And if you guys do have any questions out in the webinar world, please just type them in, and Mike will tell me, and I'll answer them to the best of my ability, and or Google them if I don't know the answer.
Okay. All right, ladies and gentlemen, welcome back. At this point, we're going to cover the next section of the program, which is the EMS specific. We're going to start out with covering the protocol. And hopefully it's easy to see for those that are on the webinar, but I am going to cover it. The first component of the suspected stroke protocol that I want to cover is the FAST scale or the Cincinnati Stroke Scale. Very often we find, and it seems to be ingrained in us from previous training, that the hardest component for EMS providers on the Cincinnati Stroke Scale is arm drift. Very often when we review charts, arm drift is not specifically mentioned or cited, even though they say the FAST scale was performed. But can anybody take a guess of what is cited besides arm drift? Grips. Everybody talks about hand grip, which testing the equality of grips, right versus left, is not a bad thing to do. It's a nice supplement to your stroke assessment, but it does not take the place of an arm drift test. So keep that in mind when you do the Cincinnati Stroke Scale. You can see on the protocol it talks about one new onset positive sign of the stroke scale, 72% chance. And it also talks about all three new onset is 85%. So that's why we activate a code stroke, or we consider early notification for a possible stroke to the receiving facility based on one new onset. Because if you look at 1 versus 3, there's not a whole lot of percentage points difference. So, you know, at 72%, you're almost 3 out of 4. That's pretty good odds. I would take those odds any day. So whenever you have one new onset in that stroke scale, we want to early notify our receiving facility. So the scale, first is facial droop. Ask your patient to show their teeth or to smile and see if you have equal showing on both sides of the face. Arm drift, have the patient close their eyes, arms out, 90-degree angle, palms up. And it's not absolutely necessary that you ask them to close their eyes, but I think it's important because, especially with that, when they talked about that left-sided stroke, it's common that they try to compensate for their deficits. So if they have their eyes closed, they won't be able to see the deficit in arm drift. If they have their eyes open, they're going to see that one arm is not moving with the other at either the same speed, pace, or at all, and they're going to try to compensate for that. So if you ask them to close their eyes, you're going to get a truer impression of whether or not arm drift is occurring. The next component is speech. Ask the patient to say a phrase, typically the same phrase every time. You can't teach an old dog new tricks. And what you're looking for is that either disability to say it or their disability to understand what you're asking of them. So either one of those is important and is considered a failure in that component. And the last one is time. The time is crucial because there are time frames and between when they were last known well and what treatment we can provide for them. So, and EMS is typically trained, has been taught to get an onset time. Really doesn't matter what their complaint is. We always want to know when it started. We take it a step further with stroke. We don't not only want to know when it started, sometimes we don't have that available. We have to know their last known well time. LKW, LKWT. If you see that abbreviation or you see that in any future training or correspondence, it's referring to last known well time. So an example of that is the patient went to bed at 10 p.m., everything was fine. You got called to the residence at 6:30 in the morning because they have left side deficit and slurred speech. Well, if the husband wakes up, finds the wife in that condition at 6:30 in the morning, their last known well was 10 p.m. the night before. So that last known well time is very crucial when we're doing our stroke scale and gathering a good patient history. Okay. When we go through the stroke protocol, number 3 is first responder care, and it starts out oxygen, check and record vital signs. And oxygen is important, and it's the foundation for a good assessment and oxygenation, or the foundation for every level of this regional protocol. So if you go to the next page to BLS care, you see it starts out the same way. Initiate an ALS intercept if possible, and you're going to check their GCS and vital signs every 5 minutes, because whether it's stroke or not, in EMS, our critical patients get reassessed every 5 minutes. Our non-critical or stables are reassessed every 15. So, and then when we get into ILS and ALS care, it starts out again with oxygen, even if it's 2 liters. We want to try to keep their saturations at or above 95 to try to feed the penumbra as much as possible and save as much of that partially infarcted area as we can for better patient outcome. 5.3, perform blood glucose level. Unless you have a mechanical failure, an equipment failure, there should never be a reason why you don't have an AccuCheck on a suspected stroke. It's probably our largest stroke mimicker, but it's the quickest to rule out, and so we want to have that done. Okay. Also on 5.7, when we're under ALS care, contact medical control if the systolic blood pressure is greater than 220 or the diastolic is greater than 110. Any of you that have been working in this field for a while, you know that it's common to have an element of hypertension whenever there's an active stroke occurring. And the reason why that happens is the body is trying to provide additional blood circulation or oxygenation to areas that don't have it. So having a patient that is somewhat hypertensive is normal. But if their systolic gets above 220 or their diastolic above 110, we need to address that hypertension at that point, and the drug of choice for that is labetalol. Now, prior to the availability of labetalol, one of the common medications that we would use would be nitroglycerin, but we want to stay away from nitro whenever we're treating a stroke because we don't know if it's ischemic or hemorrhagic. So we really don't want to give a vasodilator to an active bleed. So labetalol would be the drug of choice for that. Okay. Any questions on the basics of stroke treatment to this point? Okay. So early notification, or in the terminology of SIH facilities, calling a code stroke. Anytime you suspect possible stroke, you need to make that fact known to the receiving facility. But this code stroke call, or the early notification to get their stroke system in motion, should occur if their last known well time is within the last 6 hours. Now, AHA's initial time frame is 0 to 3, and for full out use of TPA, that's correct. But at least within SIH facilities, there are also measures that can be taken from 3 to 4.5 hours, and then from 4.5 to 6 hours. So if you find that their last known well is from 0 to 6 hours, you can early notify. You can early activate the stroke system based on that time frame. Okay, so our first scenario, 5 Queen 23 receives a 911 dispatch to respond to 927 Division Street for a 62-year-old female patient experiencing facial droop and left side weakness. Yep. So we arrive. We follow our same patient assessment algorithm that we do on every patient. So the scene is safe. We have one patient. Our nature of illness has been identified as a possible stroke. We don't have any need for additional resources, and there's no need for C-spine stabilization. So now we go to primary survey. Our general impression as we approach the patient, they appear anxious, and they have obvious facial droop that you notice as you're approaching them without even asking them to smile. They're conscious, alert, and oriented. And when you ask, their chief complaint is left side weakness. They have a patent airway, and their breathing rate and effort is adequate. So then circulatory status, they have good bilateral peripheral pulses, no obvious bleeds. And our transport decision, just based on our initial assessment, this is a priority patient because they're, even without completing the stroke scale, they're showing us signs and symptoms of stroke. So now we take their vital signs. Blood pressure 168/90, which we discussed earlier, that a level of hypertension is very common with our stroke patients. Pulse is 110 and regular. Respirations are 20. Lung sounds clear. Pulse ox 97% on room air. What is another component? Blood sugar, AccuCheck, and it's 101. So at that point, with just a finger stick, we can rule out the possibility of hypoglycemia being a mimicker for a possible stroke. So at this point, we're obtaining a history, choosing an appropriate assessment. So we're going to do a focused medical exam on this patient. We notice obvious left side facial droop, left side weakness, left arm and leg involvement. Pupils are equal and reactive, and the patient has good peripheral pulses. So now we obtain our sample history. Signs and symptoms we've discussed: left side facial droop, hemiplegia, slurred speech, and anxiety. The patient's allergic to penicillin. Medications: glucophage and an 81 milligram aspirin daily. So based on those meds that they gave to us, what kind of history could we expect? Type 2 diabetes, possible cardiac history, or a preventative measure based on their diabetic history. So last oral intake, grilled chicken, fries, and a diet soda about 30 minutes before. And then events leading up to, no specific event led up to, it was a sudden onset for our patient. So now we look at the OPQRST, getting the history of the medical condition. Onset was 5 minutes prior to the 911 call. Okay, commonly in our patient care reports, EMS document symptoms started 10 minutes prior to the call for EMS. And what the stroke center staff has told us is that when that's a very subjective time measurement. That what they find is when they actually talk to the family, and because before TPA is given, they have to track down a true last known well, so they can gauge how much time has taken place on whether or not that patient can have TPA at all. And what they're finding is that 10 minutes prior to EMS call, 15 minutes prior to arrival, they're finding that those numbers are way off from the last known well time. So it's important for us as EMS providers, when we have a possible stroke, is to try to nail down with the family as early as we can, because we're going to be their first professional medical contact. We have the greatest possibility of getting the correct answer on that last known well. So we need to be diligent about trying to get that. So no provoking factors, and it was rapid onset with no improvement prior to our arrival. So now we perform a Cincinnati stroke scale. Again, we reviewed this earlier with the face. You ask them to smile or show them your teeth. Arm drift, speech, and then time of onset, or a better way of gauging it is the last known well time. So how do we treat this patient? The diagnostic equipment that we're going to use, of course, we're going to use a cardiac monitor, oxygen saturation, we're going to get a blood glucose, and we're going to do a Cincinnati stroke scale. Procedures, oxygen. We're going to provide oxygen by cannula or mask, whatever their oxygen saturation requires. If our patient's in the 90s, we want them at 95 or above. Whether we have to achieve that with cannula or mask, that depends on how they respond to your oxygen treatment. But anybody that we suspect that's having a stroke, we need to provide oxygen. IV access, we need to establish an IV or an IO. We need to have vascular access for this patient. In years past, it was strongly encouraged that EMS obtain 2 patent IVs on any suspected stroke, because these patients were no stick status for 24 hours after TPA. That's not the case today. So if you have a good opportunity for a second IV, it's a safe thing to do. Go ahead and do that. But the stroke center and with the changes in no stick status for post-TPA patients, they're really not pushing EMS to get that second line in. It's not as vital. So we just want to make sure that we do have IV access for fluids and for medication route for this patient. As far as fluid delivery, it would be blood pressure and patient condition specific, but probably, at least for our patient in this scenario, it would just be a TKO rate. And then a semi-Fowler's position. If their systolic BP is greater than 100, we want the head of the bed elevated at 30 degrees to help take some of that pressure off of that intracranial pressure off the brain. So the detailed physical exam portion of our assessment, we're going to do that as time and patient condition permits while we're en route to the hospital. So our reassessment portion of assessment, we repeat the initial assessment, repeat our vital signs, and we check interventions. And we do this every 5 minutes for our priority patients and every 15 for the non-priorities, or for the stable patients. So any of our suspected stroke patients, we're going to be reassessing them every 5 minutes. We're going to be checking vital signs. We're going to be checking any interventions we've done, and also documenting if any of the conditions that we noted in the stroke scale, if they've changed, gotten better or gotten worse. And both of those are completely plausible with a stroke patient, because the only way to tell for us between a stroke and a TIA is the symptoms resolving. So if we have a patient that's symptomatic and fails the stroke scale, we have to assume it's a stroke. We're en route to the hospital. Their speech isn't slurred anymore. They understand what we're saying, and they have no more deficits. It's a pretty good possibility it was a TIA and it resolved en route to the hospital. So any reassessment changes, good or bad, need to be documented. Okay, any questions on that first scenario? Yes, that's correct. The question here was, if you activate a code stroke or you early notify your receiving facility and the patient's symptoms do resolve en route, the answer is yes, we do want you to notify med control or your receiving facility, make them aware of those changes, and let that individual facility decide whether to maintain their status of early notification or to change that. That's completely up to them. Okay, our second scenario, 5 Queen 12 receives a 911 dispatch to respond to 927 High Road for a 49-year-old male having a stroke. Family reports the patient had a seizure and then had trouble speaking. Also, the patient had another seizure prior to EMS arrival. That's the report you received through your dispatch center. So when you arrive, the scene's safe. You have one patient reported as a possible stroke, no need for additional resources, and no need for C-spine stabilization. When you arrive, your impression of the patient as you approach, they're postictal. They appear postictal, and you see possible facial droop. They only respond to painful stimuli when you arrive and get up to the patient. So at this point, your chief complaint would be an altered level of consciousness. Airway's patent and breathing is adequate. Bilateral pulses are good. Skin is normal. No bleeds. So an altered level of consciousness is a priority patient for us. So once we make our transport decision that this is a load and go, now we're taking vital signs. Blood pressure 158 over 92. Pulse is 88 and irregular. Now, without access to a cardiac monitor, most of the time when we palpate a pulse and it's irregular, what underlying rhythm do we find? Atrial fib. Respirations are 12, regular. Lung sounds clear. Pulse ox is 96%. And the other vital sign for our possible strokes, blood glucose is 99. So for our patient, we're going to do a focused medical exam. So we do notice obvious left side facial droop, and we note that they have a postictal appearance and they're altered. Pupils do react, and then they have good skin color and condition. So as we perform a sample history, we find left side facial droop, postictal state. They have allergies to augmentin, sulfa drugs, and IVP dye. Okay, their medications, metoprolol, Rhythmol, and phenobarbital. So based on those meds, what kind of history could we assume off of this patient? Hypertension, atrial fib, and a seizure disorder. Their last oral intake was pizza and beer 2 hours prior. So this could be a paramedic in this scenario. So events leading up to it, there was no specific event that led to the condition. It was a sudden onset, according to family and bystanders. So the onset, again, 5 minutes prior to 911 call. That last known well we want. What provoked it was unknown, but we did get a report a seizure occurred first. So rapid onset and no improvement since our arrival. So we perform a Cincinnati stroke scale. For a patient that's altered, we have an altered mental status, and we notice an obvious facial droop. Since the patient at this point can't participate anymore, we would consider this a failure of the stroke scale, but that's how we want to report it to the receiving facility or medical control, is that we see obvious facial droop, but the patient is altered and is unable to follow commands and complete the entire scale. So for this patient, we want a cardiac monitor, O2 sat, blood glucose, stroke scale, oxygen, cannula or non-rebreather, not only because there's a possibility of stroke here, but this patient's altered, so oxygen is an absolute must for us. IV access, and then semi-Fowler's position if we suspect stroke. And then also we want to take seizure precaution because we were told that we had 2 happen prior to our arrival. So watch for seizure activity and consider a benzodiazepine, have it ready in the event of another active seizure. In our detailed exam, complete that when transport time and condition allows. And then our reassessment. repeat initial assessment, vitals, interventions, and then we're going to check this, we're going to reassess this patient every 5 minutes. So let's talk about this patient. The patient was reported to have a seizure prior to what the family described as stroke-like symptoms, and then had a seizure again. Okay. Does alcohol lower the seizure threshold? I don't have an answer for that. Unsure, but thank you for the question. But one of the things that we're going to talk about, we don't know how much alcohol they've consumed, but there are multiple considerations here from the stroke standpoint. We had a seizure occur first, and then they saw symptoms that appeared to be a stroke. And postictal state and post-seizure is one of the largest stroke mimickers once you get past hypoglycemia. So anytime you have a patient that has seizure activity first, they are not a code stroke candidate. Melody, do you have a question for us? Okay, it's being typed now. We'll address it here shortly. The important thing for us as paramedics, EMS providers out in the field, is to understand those common mimickers. Number one is hypoglycemia. The second one is postictal state or post-seizure. Even if they're not completely unresponsive, you know, most of the time our postictal patients are blue and completely unresponsive. They slowly start to gain responsiveness. Sometimes they become incontinent. There are times where they may not be completely unresponsive, and they'll have weakness on one side or present with weakness and what appears to be facial droop, nystagmus, where the eyes will track and they'll jump when they track. So post-seizure conditions can mimic a stroke. So when you have a patient and you know that the seizure activity started first, those are patients that we're not going to activate code stroke for. Now, with that being said, go ahead with the question.
The question is, what about if someone who doesn't have a history of seizure activity but has a stroke symptom?
Okay, the question was, what happens if you have a patient without a history of seizure and the stroke symptoms occurred first? It would be just the opposite of what I discussed. If the stroke happens first, they're going to be treated for stroke. Strokes can cause seizures. So it's important in our history that we gather either from the patient, from family, or bystanders which one occurred first. Now, honestly, all of us know that we're going to come across situations where we're not going to get a good history. We won't know which one occurred first. Okay? And if that's the case, we're going to err on the side of caution. And just to make the medics aware, those that are participating, if we call a code stroke or we activate an early activation program for a receiving facility and they arrive and they're not a TPA candidate or they're not an early activation candidate, they just tell everybody, okay, it's canceled. It's not like they activate, you know, the National Guard and the militia and everybody gets up and runs to all this one place. It's something that can easily be canceled and reversed, but it doesn't work as well the other way. If we don't err on the side of caution and the patient is a TPA candidate, is an active stroke, and we lost 20, 25 minutes out of their 3, 4.5, or 6 hour window, that's more brain cells that are gone. So the answer to that question is, if the stroke occurs first, we early activate for that stroke. Okay, and some other questions on this patient that should be presented, should be brought up during history is you could see from the scenario that they gave us medications. And the patient really couldn't respond to us, and we gathered the history based on what we saw in the medications. So what is the number one cause of seizure? Anybody know? Non-compliance with meds. So that would be, besides our stroke history, stroke assessment, that is a question that we're going to want to ask as EMS providers when we're assessing this patient. A question we're going to try to find an answer to is the patient compliant with their phenobarbital? Okay. Are there any other questions? Okay. Any comments? Anybody in the classroom? Did I miss anything? Nathan? Okay. 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 Nathan mentioned from the quality standpoint on documentation that you make sure that you document the stroke scale, especially arm drift versus grip, and that reassessments are documented on these patients that we consider critical, that are reassessed every 5 minutes. And if we have no more questions, that is all the scenario-based that I have for EMS today. So I want to thank everybody for coming. Thank you, everyone, for participating through GoToMeeting. And we have one more poll for those of you in the virtual world to answer before we finish. Okay, also for those of you on GoToMeeting, if you come up with questions, even after I sign off here locally, you can still type those questions in and we will address those as well. For a short time, but we're not going to leave Mike here all day. So, okay. Well, 15 seconds on the poll. But I do want to take this this time again to thank everybody, especially for those who participated live on scene here at John A. Logan College. We've had a very difficult time logistically getting this meeting to occur, this training session. So for those of you who have been bounced around on your schedule from either days or locations, especially location today, we do apologize for that. That was completely outside of our hands as far as EMS, but we adapted and made it happen. So, and be sure and let your friends know and coworkers that this webinar is being recorded, and it'll be available on the system website, sirems.com. And hopefully by the end of the week, we'll have it posted on the website. And for those that could not participate live with us today, either remotely or in person, you can view the webinar and take an attached quiz, and you can receive your CEUs that way as well. So again, thank you, everybody, and have a wonderful afternoon.